a rigorous study of ocular pathology, focusing on the cellular deviations and structural alterations that occur when the eye's homeostatic mechanisms fail. This field demands an analytical approach to how specific disease processes, such as inflammation, degeneration, or neoplasia, disrupt the delicate architecture of ocular tissues. Can you identify the primary histological layers that must remain perfectly transparent to ensure the proper transmission of light to the photoreceptors? Throughout these modules, we will correlate these underlying biological changes with their functional consequences, transforming our understanding of vision loss from a symptom into a defined scientific process. This analytical matrix serves as a coordinate system for pathology, intersecting anatomical structures with their specific pathophysiological triggers. By mapping conditions like retinoblastoma or choroidal melanoma along these axes, we can differentiate between developmental errors in genetic coding and acquired cellular mutations. Notice how metabolic stressors uniquely impact highly vascularized zones like the retina, leading to the complex vascular occlusions and exudates listed in our third row. Why would a structural defect like a coloboma be categorized as congenital across multiple columns, rather than a traumatic event? Mastery of this grid enables us to systematically isolate the biological origin of any clinical presentation by evaluating the intersection of tissue type and disease mechanism. Our focus now shifts to the specific pathogenic states that exhibit the highest statistical frequency within the human visual system. We are analyzing why certain tissues demonstrate a higher susceptibility to cellular degradation or inflammatory cascades than others. What role do the differing metabolic requirements of the corneal endothelium and the retinal pigment epithelium play in the prevalence of the disorders we observe? By examining these common pathologies, we will decode the underlying biochemical failures that lead to the most frequent interruptions in the visual pathway. We are zooming in on the eyelids, the dynamic anatomical barriers that provide both mechanical protection and essential biochemical maintenance for the ocular surface. Consider how the stratified squamous epithelium of the skin transitions at the lid margin to the mucocutaneous junction, a critical zone for pathological shifts. Based on the histological composition, which specific adnexal glands would you expect to be the primary site for sebaceous carcinomas or acute bacterial infections like a hordeolum? Understanding the tarsal plate's structural rigidity and the orbicularis oculi neuromuscular control is vital for diagnosing functional disorders that compromise the integrity of the precorneal tear film. Examination of the eyelid margins reveals the chronic inflammatory state known as blepharitis, characterized by significant architectural changes at the base of the cilia. This pathology typically arises from staphylococcal colonization or seborrheic dysfunction, leading to the formation of the distinctive crusting and collarettes visible in these clinical images. Why does this localized inflammation frequently cascade into secondary ocular surface issues like evaporative dry eye? Our management strategy addresses this by utilizing thermal energy to lower the viscosity of sequestered sebaceous secretions, coupled with mechanical debridement to neutralize the microbial and inflammatory bioburden. Let's analyze the pathophysiological shift from acute infection to the chronic granulomatous state known as a chalazion, where the primary failure occurs in the meibomian gland's drainage. When the glandular duct becomes obstructed, the resulting lipid accumulation triggers a sterile, cell-mediated immune response that manifests as a firm, painless nodule within the tarsal plate. What specific cellular mechanisms cause the surrounding tissue to form a granuloma around these escaped lipids, rather than clearing them through standard lymphatic drainage? We address this obstruction by utilizing exogenous heat to lower the viscosity of the trapped sebum, though surgical intervention becomes necessary when the lesion undergoes significant fibrotic encapsulation. Differentiating between a chalazion and a sty requires a precise analysis of their underlying immunological states. The former is a chronic, non-infectious granulomatous reaction, while the latter represents an acute, suppurative bacterial invasion, typically by Staphylococcus. Notice how the anatomical location dictates the clinical symptoms. The sty's superficial position at the lid margin triggers rapid nociceptor activation and acute pain, whereas the deeper, sequestered meibomian blockage in a chalazion results in a slow-forming, painless mass. Why does the treatment protocol for a sty necessitate antimicrobial intervention, while a chalazion focuses on liquefying trapped lipids or surgical debulking of the granuloma? We are essentially contrasting a sterile lipid-induced inflammatory cascade against a localized pyogenic infection that yields distinct architectural changes at the eyelid's edge. We are pivoting our investigation toward the lacrimal apparatus, the integrated physiological system responsible for the continuous synthesis and controlled evacuation of the precorneal tear film. This system operates through a precise homeostatic balance between the secretory output of the main and accessory lacrimal glands and the hydraulic pressure gradient that drives fluid through the puncta into the nasolacrimal duct. What biochemical alterations in tear osmolarity or lysozyme concentration might occur if the lacrimal gland's acinar cells undergo autoimmune-mediated apoptosis? Mastering the anatomical pathway from the superior temporal orbit to the inferior meatus of the nose is essential for localizing obstructive pathologies that disrupt this vital fluid dynamic. Dacryocystitis arises when a mechanical or membranous obstruction in the nasolacrimal duct halts tear drainage, transforming the lacrimal sac into a sequestered reservoir for bacterial colonization. We categorize these failures into acute, purulent episodes and chronic states where persistent stagnation triggers recurrent inflammation and significant epiphora. Examine the anatomical shifts at the medial canthus. What physiological factors determine whether this localized infection remains contained or progresses toward life-threatening intracranial complications like meningitis? Our clinical response involves aggressive antimicrobial therapy with agents such as clindamycin or vancomycin, followed by dacryocystorynostomy to surgically reconstruct the hydraulic pathway into the nasal cavity. Dry eye disease originates from a breakdown in the homeostatic balance of the tear film, specifically when the rate of production falls below the rate of evaporation. This trilaminar structure, composed of an anchoring mucin layer, a hydrating aqueous layer, and an evaporation-resistant lipid layer, is evaluated using the Schirmer test to measure volume and the tear film breakup time to assess kinetic stability. Why do the rose bengal and lissamine green dyes specifically highlight areas of cellular death and devitalized mucin rather than simply marking the presence of tears? To counteract this cellular degradation, we employ punctal plugs to mechanically obstruct the drainage canaliculi, effectively increasing the residence time of the remaining fluid on the corneal surface. This intervention, combined with osmolarity testing, allows us to transition from symptomatic relief to a targeted restoration of the ocular surface microenvironment. We must categorize these dry eye triggers by their physiological impact, starting with systemic autoimmune conditions like Sjogren's syndrome, where lymphocytic infiltration directly destroys the lacrimal gland's secretory architecture. How do you think the mechanical eversion of the eyelid in ectropion, or the inversion in entropion, fundamentally alters the hydraulic resurfacing of the cornea during a blink cycle? Pharmacological agents like beta blockers and diuretics further complicate this by modulating autonomic receptors, which significantly suppresses the neural drive for aqueous production. Furthermore, environmental stressors and reduced blink frequency during high-intensity cognitive tasks accelerate tear film evaporation, stripping away the protective lipid barrier and exposing the corneal epithelium to desiccating stress. Our focus shifts to the conjunctiva, a highly vascularized, translucent mucous membrane that serves as a critical immunological and mechanical barrier for the ocular surface. This tissue is architecturally unique, featuring a non-keratinized stratified columnar epithelium interspersed with specialized goblet cells. These goblet cells are the primary synthesizers of the tear film's glycocalyx and mucin layer. How do you think a depletion of these cells would compromise the anchoring of the aqueous layer to the corneal symphysis? By differentiating the palpebral conjunctiva lining the inner lids from the bulbar conjunctiva covering the anterior sclera, we can precisely localize cellular reactions like papillary hypertrophy or follicular responses during inflammatory cascades. Trachoma represents a severe chronic infectious state where the obligate intracellular bacterium Chlamydia trachomatis triggers a persistent inflammatory response within the conjunctival tissue. This biological progression is characterized by recurrent reinfection cycles that eventually induce a fibrotic cascade, fundamentally altering the tarsal plate's structural integrity. Observe the mechanical transition into trichiasis. As the inner eyelid scars and contracts, the lashes are misdirected inward to strike the corneal surface during every blink. What molecular signals do you think are responsible for transitioning from a simple follicular inflammation into the permanent tissue remodeling seen in these advanced stages? This relentless mechanical abrasion eventually compromises the cornea's optical clarity, leading to the dense leucoma or opacification that results in permanent vision loss. The diagnostic hallmark of chronic chlamydia trachomatis infection is the formation of lymphoid follicles on the palpebral conjunctiva, which you can see as distinct, pale elevations in the upper clinical image. As these follicles undergo necrotic changes and subsequent fibrosis, the resulting cicatricial contraction pulls the eyelid margin inward, transforming simple irritation into the mechanical trauma of trichiasis. We manage this multifaceted pathology using the SAFE strategy, where oral azithromycin targets the bacterial 50S ribosomal subunit to halt protein synthesis, while surgical intervention restores the anatomical alignment of the lashes. Given the recurring nature of this infection, how do you think improving environmental sanitation and facial cleanliness serves to disrupt the pathogen's vector transmission and prevent the cascade toward permanent corneal opacification? A pterygium is an aberrant, wing-shaped proliferation of fibrovascular tissue that originates from the bulbar conjunctiva and actively encroaches upon the corneal surface. This pathological progression is driven primarily by chronic ultraviolet radiation, which catalyzes the degeneration of conjunctival collagen and triggers a cascade of inflammatory mediators and growth factors. As the lesion advances, it physically disrupts the Bowman's layer of the cornea, leading to progressive irregular astigmatism or a total occlusion of the visual axis if it reaches the central pupillary zone. Why would a breakdown in the limbal stem cell barrier be a necessary prerequisite for this conjunctival tissue to breach the corneal territory and continue its centripetal migration? The mechanical traction exerted by a pterygium's advancing head physically deforms the corneal surface, shifting the eye's refractive state toward irregular astigmatism as the symmetrical curvature is lost. Observe the surgical sequence in the diagram, where we must isolate the scleral body and then perform a precise keratectomy to peel the growth away from the underlying corneal stroma. What molecular signaling pathways do you suspect remain active in the limbal region to cause such high rates of postoperative recurrence and fibroblastic proliferation? While we use lubricants and corticosteroids to manage the inflammatory component, the ultimate objective in advanced cases is the restoration of the visual axis through this invasive structural realignment. We are now centering our analysis on the cornea, the eye's principal refractive component, responsible for approximately 2/3 of its total optical power. This tissue represents a biological marvel of transparency, achieved through a strictly avascular structure and the precise lattice-like arrangement of stromal collagen fibrils. Which physiological mechanisms do you think are responsible for maintaining the state of relative dehydration, or detergescence, necessary to prevent light scattering within this crystal-clear matrix? As we proceed, we will examine how any disruption to its 5 distinct histological layers, from the protective stratified epithelium to the metabolic pump of the endothelium, catastrophically compromises the visual pathway. Corneal opacity occurs when the structural regularity of the stroma is compromised by fibrotic scarring, genetic dystrophies, or the accumulation of metabolic deposits, like the oil-like droplets seen in climatic droplet keratopathy. Keratitis, however, represents a dynamic inflammatory emergency where pathogenic invasion, whether bacterial, fungal, or viral, triggers a rapid leukocytic infiltration and tissue degradation that can lead to permanent ulcerative perforation. What specific cellular markers allow us to differentiate a genetically driven dystrophy like Fuchs from a purely degenerative process like band keratopathy? Since both conditions fundamentally disrupt the light-bending precision of the ocular surface, surgical intervention via keratoplasty becomes the final resort for restoring the eye's optical clarity. The cornea functions as the eye's primary refractive engine, providing approximately 2/3 of total optical power through its precisely curved avascular architecture. Examine the histological section to identify the 5 distinct layers. specifically the thick stroma, where a highly ordered collagen lattice prevents light scattering to maintain absolute transparency. At the limbus, we find the critical stem cell niche required for continuous epithelial regeneration, as well as the hydraulic drainage pathways like the trabecular meshwork and the canal of Schlemm. Why does this tissue maintain such an extreme density of nociceptors while strictly excluding blood vessels from its matrix? This unique biological trade-off ensures that any threat to corneal integrity is immediately signaled to the nervous system without compromising the clarity of the visual axis. Corneal transparency is a fragile physiological equilibrium maintained by the strict spatial organization of collagen fibrils and an active metabolic pump in the endothelium that prevents light-scattering stromal edema. When this architectural precision is lost, we observe opacities ranging from post-traumatic scars to genetic dystrophies and degenerative states like climatic droplet keratopathy, where oil-like deposits physically block the visual axis. Analyze the structural divergence between the normal and keratoconic corneas in these profiles. Observe how the localized thinning and ectasia transform the corneal curvature into a cone, causing severe irregular astigmatism. What critical physiological failures occur when a limbal injury depletes the stem cell reservoir, effectively halting epithelial resurfacing and allowing opaque conjunctival tissue to invade the corneal territory? Keratoconus represents a progressive, non-inflammatory corneal ectasia, where the stroma undergoes localized thinning, causing the tissue to lose its spherical recularity and bulge into a conical profile. Analyzing the topographic map, we see this steepening depicted as a high diopter red zone. This irregular curvature, where the steep meridian significantly deviates from the flat meridian, destroys the focal precision of the eye and induces high-order aberrations. Look at the Manhattan plots from the Genome-Wide Association study. Each peak represents a genetic locus where the statistical significance, expressed as the negative logarithm of the p-value, crosses the threshold, proving that while mechanical stressors like eye rubbing are critical, there is a complex polygenic vulnerability at play. How would the systemic loss of structural rigidity in connective tissue disorders specifically accelerate this biomechanical failure of the corneal collagen matrix? Corneal topography serves as our gold standard by generating a high-resolution map of the asymmetrical steepening that defines the cone-shaped protrusion and its resultant irregular astigmatism. Slit lamp examination identifies Fleischer rings, which are epithelial iron deposits at the cone's base, and Vogt striae, representing vertical stress lines caused by the mechanical stretching of the stroma and Descemet's membrane. To halt this ectasia, we implement corneal collagen cross-linking, a process that exponentially increases the density of covalent bonds between collagen fibrils, effectively transforming a weak, sparse matrix into the reinforced architectural lattice shown in our structural diagrams. How do the biochemical properties and specific anatomical layers of the iron-based Fleischer ring differ from the copper-heavy Kayser-Fleischer ring associated with systemic metabolic failure? We are advancing our investigation into the eye's middle vascular layer, the uveal tract, which forms a continuous pigmented tunic consisting of the iris, ciliary body, and choroid. This anatomical system serves as the eye's primary metabolic engine, where the iris controls the light entry aperture, the ciliary body regulates aqueous production and lens accommodation, and the choroid provides the essential high-flow blood supply to the outer retina. Why do you think the high density of melanocytes and the complex microvasculature in this region make it particularly susceptible to both autoimmune-mediated inflammation and primary malignant growths? By mapping these three zones, we will analyze how disruptions in the blood-ocular barrier lead to the protein flare and cellular infiltration that define uveitis. We are examining uveitis, the inflammatory breakdown of the uveal tract, which is anatomically subdivided into anterior, intermediate, and posterior segments, depending on whether the iris, ciliary body, or choroid is the primary site of leukocyte infiltration. Observe the clinical hallmarks of photophobia and blurred vision, alongside the pupillary irregularities shown in the bottom diagram. Why does this inflammatory response so frequently correlate with systemic autoimmune triggers? In infectious cases, such as the herpetic, tuberculosis, or toxoplasmosis examples provided, our management shifts to a mandatory sequential protocol. We must initiate targeted antimicrobial therapy to halt pathogen replication, before carefully introducing steroids to mitigate inflammatory tissue damage. If we were to administer steroids in isolation against an active infection, we would essentially be deactivating the ocular immune response, providing the pathogen with an uninhibited environment for rapid proliferation.
Aniridia represents a profound developmental arrest where the iris fails to form, resulting in the partial or total absence of this light-regulating diaphragm, as seen in these clinical profiles. This pathology is rooted in a mutation of the PAX6 gene, which functions as the master transcription factor, orchestrating the entire ocular assembly line. Examine the developmental timeline provided. Notice how the signaling cascade moves from the early diencephalon, guided by 6-3 and OTX2, to the optic stalk, where PAX6 first emerges to coordinate with PAX2 and SOX2. In the late stages of the ocular cup, PAX6 is the essential trigger for downstream genes like PIX3 and MOTH-A. If this genetic instruction is absent or malformed, the inward migration of the neuroectodermal layers that create the iris never occurs. Considering this gene's critical role across every stage of the diagram, from the optic stalk to the lens, what secondary structural abnormalities would you expect to find in the retina of a patient born with this condition? We must differentiate between the autosomal dominant inherited form of aniridia and the sporadic variant, which frequently arises from a contiguous gene deletion at the 11p13 locus on chromosome 11. In these sporadic cases, the loss of genomic material results in Wagner syndrome, where the ocular absence of the iris is critically linked to nephroblastoma, genitourinary malformations, and intellectual disability. Analyze the optical coherence tomography scans on the right. Notice how the red arrows indicate foveal hypoplasia, a failure of the inner retinal layers to displace, which catastrophically prevents the development of high-resolution central vision. Why do you think the genetic disruption of PAX6 at this 11p13 coordinate leads to such a wide array of secondary pathologies, including the progressive cataracts and corneal opacification shown in our clinical images? This demonstrates that aniridia is not merely a pupillary defect, but a total ocular failure rooted in a major chromosomal deletion. The pathophysiology here transcends a simple missing iris. The developmental failure encompasses the entire neuroectodermal lineage, including the retina and optic nerve. Look closely at the OCT scans on the right. The white arrows highlight the complete absence of the foveal depression, a state of hypoplasia, where the inner retinal layers fail to migrate away from the central axis. This lack of a specialized central pit means the eye cannot achieve the high-resolution neural capture needed for stable fixation. So why does this lead to the rhythmic oscillations of nystagmus? Without the iris to regulate photon flux, the retina is perpetually overwhelmed by light, creating the intense photophobia we observe, alongside the profound visual impairment resulting from these combined structural deficits. The clinical progression of aniridia often culminates in secondary glaucoma, where the rudimentary iris tissue obstructs the trabecular meshwork, preventing aqueous humor outflow and elevating intraocular pressure. This mechanical stress triggers an apoptotic cascade in the retinal ganglion cells, leading to the centripetal contraction of the visual field visible in our progression simulations. Why must we prioritize abdominal imaging alongside ocular exams in sporadic cases? Because a deletion at the 11p13 locus frequently encompasses the WT1 gene, necessitating a vigilant screen for the embryonal nephroblastoma known as Wilms tumor. Our management is strictly supportive, focusing on the artificial regulation of photon flux and the rigid maintenance of a safe pressure gradient to arrest the destruction of the optic nerve fibers. We are observing how a single genetic failure manifests as a pan-ocular syndrome, disrupting the anatomical integrity of both the anterior and posterior segments. Notice how the lens abnormalities like microspherophakia and subluxation stem from a defective suspensory apparatus that fails to maintain the lens's equatorial tension and position. In the drainage angle shown at the bottom, the synechial tissue and the anterior rotation of the iris stump physically obliterate the trabecular meshwork, causing the catastrophic rise in pressure that yields the glaucomatous optic cupping we see on the right. Why does the lack of a foveal pit, foveal hypoplasia, represent a failure in the cellular migration of the inner retinal layers during late-stage development?
This comprehensive mapping illustrates that the absence of the iris is merely one facet of a global developmental collapse involving the corneal surface, the crystalline lens, and the neurosensory retina. A coloboma occurs when the choroid fissure, the temporary opening on the ventral surface of the optic cup, shown in the top diagram, fails to achieve complete fusion during the 7th week of embryonic development. This fissure normally facilitates the entry of hyaloid vessels into the vitreous cavity. However, an incomplete closure results in the characteristic keyhole-shaped defect, localized strictly to the inferior aspect of ocular structures. As you examine the 3 clinical variations, observe how this anatomical gap can manifest in the iris, the retina, or even the optic nerve head, depending on the extent of the fusion failure. If a retinal coloboma involves the macula, why would we expect a profound loss of central visual acuity compared to a localized iris defect that only affects light regulation? This pathology illustrates how a singular interruption in the zippering of the optic cup produces permanent architectural voids across multiple tissue layers. We are pivoting our focus to the crystalline lens, a biconvex and perfectly avascular structure that provides the eye's essential fine-tuning for optical refraction. Unlike the cornea, which provides static refractive power, the lens utilizes its dynamic elasticity to alter its curvature through the physiological process of accommodation. This transparency is maintained by a highly organized arrangement of specialized crystalline proteins. What biochemical stressors do you think would cause these proteins to aggregate and scatter light, leading to the formation of a cataract? Suspended by the ciliary zonules, this unique tissue must remain entirely devoid of blood vessels and nerves to ensure an unobstructed pathway for incoming photons. Let's analyze the transition of the crystalline lens from absolute transparency to a state of pathological opacification known as a cataract. Observe the morphological divergence between the dense, fully opaque mature cataract and the wedge-shaped opacities of a cortical cataract, both of which fundamentally scatter light rather than focusing it on the retina. To reverse this, we employ phacoemulsification, a 4-step mechanical process where we initiate a corneal incision and utilize ultrasonic energy to break the protein aggregates into microscopic fragments for aspiration. How does the systemic biochemical stress of uncontrolled glucose and diabetes specifically accelerate this protein cross-linking and denaturation, compared to the slower metabolic decline seen in age-related cataracts? By replacing the biological lens with a clear intraocular implant, we effectively restore the eye's refractive integrity and eliminate the glare caused by these disorganized protein structures. Ectopia lentis represents a mechanical failure of the zonules of Zinn, where the partial rupture or structural weakening of these suspensory ligaments causes the crystalline lens to deviate from its central visual axis. We differentiate the underlying genetic etiologies by the specific direction of displacement. The fibrillin 1 deficiency in Marfan syndrome typically drives a supratemporal shift, while the metabolic dysfunction in homocystinuria manifests as an inferonasal subluxation. This loss of anatomical centration generates severe lenticular astigmatism and can trigger secondary glaucoma if the displaced lens physically obstructs the pupillary aperture or compromises the hydraulic drainage of aqueous humor. Why would the accumulation of proteinaceous material in pseudoexfoliation syndrome specifically target the integrity of these zonular attachments to cause the progressive instability visible in these clinical images? Our investigation now penetrates the posterior segment to analyze the retina, a sophisticated neurosensory tissue where the biochemical process of phototransduction translates electromagnetic radiation into action potentials. This intricate 10-layer architecture relies on the metabolic synergy between the photoreceptors and the underlying retinal pigment epithelium to sustain continuous visual cycles. What specific physiological mechanisms allow the retina to maintain the highest oxygen consumption rate per gram of tissue in the entire human body? We are moving beyond simple light perception to examine how precise neural circuits within this tissue begin the complex task of visual processing before signals even reach the optic nerve.
Retinitis pigmentosa represents a diverse group of inherited dystrophies where genetic mutations, ranging from autosomal dominant to X-linked patterns, trigger the progressive apoptosis of the retinal photoreceptor cells. Since the rod system is typically targeted first, the pathology manifests as an initial loss of scotopic sensitivity, followed by the centripetal contraction of the visual field into tunnel vision. Examine the diagnostic triad in these images. The migration of pigment into the sensory retina forms those distinctive bone specule deposits, which appear alongside severely attenuated blood vessels and a waxy pallor of the optic nerve head. Why do you think the electroretinogram shows a drastically reduced electrical response even before these structural changes become clinically obvious? This progression highlights a relentless cellular collapse that eventually migrates from the periphery to the macula, systematically extinguishing the remaining cone-mediated central vision.
We are investigating the interrupted maturation of the retinal vasculature, where the interplay between prematurity and oxygen therapy results in a state of severe peripheral hypoxia. This metabolic stress triggers a critical biochemical cascade. Hypoxia leads to an upregulation of vascular endothelial growth factor, or VEG, which acts as the primary molecular signal for the disorganized extraretinal fibrovascular proliferation visible in stage 3. As this abnormal tissue matures, it creates powerful mechanical traction, clearly illustrated in stage 4, that physically lifts the retina from its anatomical base, leading to subtotal or total detachment. By applying laser energy to ablate the ischemic peripheral tissue, we effectively terminate the source of VEG production. Why would reducing the overall metabolic demand of the peripheral retina in this way be the most effective method to arrest the growth of these pathological vessels?
High oxygen concentrations initially trigger a downregulation of vascular endothelial growth factor, causing the vasoobliteration and significant avascular zones visible in panel B. Once the tissue returns to room air, the resulting relative ischemia sparks a massive upregulation of VEG as the retina attempts to compensate for the lack of perfusion. This molecular surge drives the formation of the pathological neovascular tufts shown in panel C and the OIR retina image, where disorganized vessels breach the internal limiting membrane rather than providing functional blood flow. Look at the vascular density in the OIR image versus the normal retina. Why would these localized, leaky clusters be incapable of supporting the high metabolic demands of the underlying photoreceptor layers? Our clinical objective is to facilitate the regression seen in panel D by neutralizing these effector molecules and preventing the fibrovascular traction that leads to retinal detachment.
Normal retinal vascularization is a timed migration from the optic disc to the periphery that completes at 40 weeks. But premature birth halts this process, leaving the distal retina in a dangerously avascular state. When high supplemental oxygen is introduced in the ICU, it triggers phase 1 by downregulating vascular endothelial growth factor, which causes the existing vessel front to stop or even regress. Once the metabolic demand of the developing retina outpaces this stunted supply, we enter phase 2, where severe hypoxia drives a massive surge in VEG production, resulting in the fragile, leaky neovascularization seen in stage 3. These abnormal vessels act as a scaffolding for fibrous tissue that, upon contraction, exerts enough mechanical force to physically pull the neurosensory retina away from the pigment epithelium. Given this sequence, how does the transition from a simple demarcation line to a thickened ridge signify the shift from a stagnant growth front to an active pathological proliferation? We are dissecting the microvascular destruction that characterizes diabetic retinopathy, beginning with the transition from systemic hyperglycemia to localized endothelial dysfunction. In the non-proliferative phase, follow this biochemical sequence. Chronic diabetes triggers endothelial damage, which increases vascular permeability and leads to fluid leakage, culminating in the macular edema and microaneurysms seen in our middle diagram. When this vascular compromise reaches a tipping point of retinal hypoxia, the tissue responds by upregulating vascular endothelial growth factor, or VEG, initiating the second pathway. Hypoxia triggers VEG, which drives the abnormal angiogenesis defining proliferative retinopathy. Why would the body's attempt at revascularization through these fragile new vessels on the right ultimately result in a total loss of vision rather than restoring oxygenation to the ischemic retina? This catastrophic outcome occurs because the newly formed vessels lack structural integrity, leading to the massive hemorrhaging and tractional forces that destroy the delicate neurosensory architecture.
Observe the pathological progression from the baseline normal retina to the catastrophic architectural failure of proliferative disease. In the non-proliferative phase, we see the results of increased capillary permeability. Blood components escape into the tissue, manifesting as microaneurysms, scattered hemorrhages, and the yellow protein lipid clusters known as hard exudates. How does the transition to the proliferative stage, marked by those disorganized vascular tufts, fundamentally alter the refractive and neural environment of the eye? These incompetent new vessels are prone to rupture, which creates the dense, irregular scotomas you see obscuring the central vision in the clinical simulation. This cycle of ischemia and aberrant vessel growth serves as a biological feedback loop that systematically compromises the integrity of the macula and the transmission of light to the photoreceptor layer.
The pathological signature of non-proliferative diabetic retinopathy involves the progressive breakdown of the blood-retinal barrier, visible here as a constellation of vascular and extravascular defects. Markers 3 and 8 illustrate how chronic hyperglycemic stress weakens capillary walls to form microaneurysms, while venous beading signals severe localized hypoxia and impending circulatory collapse. The varied morphology of the hemorrhages, from deep, rounded dots to superficial, flame-shaped streaks, reflects the specific retinal layer where the vessel wall has breached. What biochemical shift causes the transition from the yellow, lipid-rich hard exudates at point 1 to the pale ischemic cotton wool infarcts at point 2? These intraretinal microvascular abnormalities, or IRMAs, indicate that the retina is already attempting to bypass non-perfused capillary beds, marking a critical threshold before the transition to proliferative disease. Contrast the pristine, uniform perfusion of the control retina on the left with the profound architectural collapse seen in the non-proliferative diabetic state on the right. Chronic glucose-induced weakening of the capillary basement membrane manifests first as focal outpouchings or microaneurysms at point 2, which eventually rupture to create the varying morphologies of hemorrhages at markers 3, 4, and 5. Why does the anatomical depth of the bleed dictate whether we see a spherical dock or a horizontally oriented flame guided by the nerve fiber layer? Simultaneously, the waxy clusters at marker 1 are hard exudates, representing the solid protein and lipid residues left behind after the aqueous component of leaked plasma has been resorbed. This visual map illustrates the shift from a high-integrity barrier to a porous system that systematically compromises the metabolic stability of the neurosensory retina. Age-related macular degeneration targets the macula, the specialized central region of the retina responsible for high-acuity vision, leading to the dense central scotoma visible in our visual simulation. In the non-exudative or dry form, metabolic byproducts known as drusen accumulate between the retinal pigment epithelium and Bruch's membrane, causing progressive atrophy of the overlying photoreceptors. Conversely, wet AMD involves the pathological growth of abnormal vessels from the choroid, a process called choroidoidal neovascularization, which breach the retinal layers and leak fluid or blood, resulting in rapid architectural distortion. Why does the transition from stable drusen to active neovascularization trigger such a sudden and profound drop in central visual acuity compared to the slow geographic atrophy of the dry type? By analyzing these fundus images, we can see how the accumulation of these proteinaceous deposits effectively suffocates the metabolic exchange required for clear central perception. Focus your attention on the yellowish clusters highlighted in the superior region, which represent drusen, complex extracellular accumulations of lipids and metabolic proteins sequestered between the retinal pigment epithelium and Bruch's membrane. In contrast, the green circled zone identifies choroidal neovascularization, or CNV, where pathological vessels from the choroid have physically breached the outer retinal layers. Unlike the slow metabolic decline associated with drusen, these neovascular membranes are inherently fragile and prone to leakage, leading to the sudden exudative changes that define wet macular degeneration. Consider the biochemical environment. Why would the chronic inflammation triggered by these drusen deposits serve as a potent catalyst for the pro-angiogenic signals that drive this invasive vascular growth?
Retinal health hinges on the precise maintenance of a high-pressure arterial inflow and a low-pressure venous outflow, both of which are catastrophically disrupted in these occlusive states. In central retinal artery occlusion, the resulting panretinal ischemia produces a hallmark pale fundus. However, the fovea remains a cherry red spot because its oxygenation is sustained by the underlying choroidal circulation, which is anatomically distinct from the blocked retinal artery. This represents a critical ischemic event, where neurosensory viability is lost after a threshold of only 90 to 120 minutes, requiring a management urgency identical to an acute cerebral stroke. By contrast, central retinal vein occlusion generates a blood and thunder appearance, as the outflow blockage creates massive hydrostatic back pressure, forcing blood to rupture through capillary walls into all four quadrants. What physiological factors explain why the sudden cessation of oxygen delivery in an artery causes instantaneous blindness, while the buildup of pressure in a vein leads to the more gradual hemorrhagic vision loss we see in these lower images?
Retinal detachment occurs when a mechanical break or tear allows liquefied vitreous humor to infiltrate the subretinal space, physically decoupling the neurosensory retina from the underlying retinal pigment epithelium. This hydraulic separation effectively severs the photoreceptors from their primary metabolic lifeline, the choroid, which manifests clinically as a progressively expanding curtain-like scotoma. Notice in the anatomical diagram how the vitreous fluid actively displaces retinal tissue. What specific cellular failures would you expect to occur once the metabolic exchange between the RPE and the outer segments of the rods and cones is terminated? The accompanying flashes and floaters serve as a neural alarm, triggered by the vitreous humor exerting mechanical traction on the retinal surface before the total structural collapse occurs. Because the retina is an extension of the central nervous system, this separation represents an acute ischemic emergency, where every hour of detachment increases the risk of permanent, irreversible apoptotic cell death.
Analysis of the optical coherence tomography scan on the right reveals a distinct hyporeflective void that confirms the physical divergence of the neural retina from the underlying retinal pigment epithelium. This pathological detachment turns a potential space into a fluid-filled gap, as evidenced by the high elevation of the retinal layers seen in both the cross-sectional OCT and the hazy, convex appearance in the fundus photo on the left. What specific metabolic failure occurs in the photoreceptor outer segments once they are sequestered from the RPE's nutrient transport and phagocytic support? This structural failure represents a critical interruption in the visual cycle, where the lack of subretinal adhesion effectively shuts down the phototransduction process in the detached zone. Examine the topographical disruption in row A, where the neurosensory retina is vaulted upward by an accumulation of subretinal fluid, highlighted by the white stars. This hyporeflective void on the OCT cross-sections signifies a total mechanical and metabolic disconnect between the photoreceptors and the supportive retinal pigment epithelium, fundamentally halting the visual cycle. What specific physiological mechanisms must we engage to collapse this potential space and restore the anatomical apposition visible in the healthy, reattached profile of row B? Observe how the return of the sharp foveal depression in the bottom scans confirms that the hydraulic barrier has been neutralized, allowing the cellular layers to resume their vital metabolic interdigitation. Optical coherence tomography provides an unprecedented view into the stratified architecture of the retina, pinpointing the vitreoretinal interface where the posterior hyaloid adheres to the inner limiting membrane. Analyze the healthy scan to identify the hyperreflective nerve fiber layer and the distinct nuclear and plexiform layers that coordinate the eye's primary neural processing. Contrast this with the pathological cross-section on the right, where a massive hyporeflective void signifies a mechanical failure at the juncture of the neural retina and the retinal pigment's epithelium. What physiological consequences arise when the outer nuclear layer, the home of our photoreceptor nuclei, is stripped away from the metabolic support of the underlying choroid and RPE? This detachment signifies a catastrophic interruption of the visual cycle, as the neurosensory tissue becomes hydraulically isolated from its essential biochemical recycling center. Glaucoma arises when a disruption in the hydraulic balance of aqueous humor elevates intraocular pressure, triggering a mechanical and ischemic insult to the optic nerve. Compare the two fundus images. Notice how the cupping in the right image represents the physical excavation of the optic disc, as the neuroretinal rim, the bundle of over 1 million ganglion cell axons, systematically thins and dies. We categorize these failures based on the accessibility of the drainage angle, contrasting the chronic, silent progression of open-angle cases with the sudden, agonizing pressure spike of an acute angle closure emergency. Our therapeutic objective, whether through prostaglandin analogs or surgical trabeculectomy, is to restore a sustainable pressure gradient to protect the remaining axonal fibers. How does the expansion of this central white cup specifically correlate with the characteristic peripheral field defects observed during clinical perimetry testing? Aqueous humor synthesis occurs within the ciliary body, where the fluid is secreted into the posterior chamber before circulating through the pupillary aperture into the anterior chamber. This continuous flow provides essential nutrients to the avascular crystalline lens and cornea, while maintaining the precise intraocular pressure necessary for ocular structural integrity. Look closely at the histological slide on the right to identify the trabecular meshwork and the canal of Schlemm, which serve as the primary exit filters for this fluid into the venous system. If these drainage channels become physiologically compromised or physically obstructed at the iridocorneal angle, what catastrophic pressure-driven condition begins to destroy the retinal ganglion cells of the optic nerve? By tracing the red dashed trajectory in the anatomical diagram, we can see how the delicate balance between ciliary production and trabecular outflow dictates the entire hydraulic health of the eye. Glaucoma represents a failure in ocular fluid dynamics, where elevated intraocular pressure, shown by the radial arrows in the top left, exerts a mechanical force that systematically destroys the optic nerve's axonal fibers. In open-angle glaucoma, the iridocorneal angle remains patent, but the trabecular meshwork's resistance is pathologically high, whereas angle closure involves a physical blockade where the iris prevents fluid from reaching the drainage channels. Examine the laser iridotomy intervention in diagrams C and D. We utilize coherent light to create a full-thickness iris bypass, equalizing the pressure between the chambers and pulling the iris tissue away from the meshwork to restore hydraulic outflow. Why would this anatomical shift be necessary to halt the cupping or excavation seen in the right fundus image, which represents the permanent loss of the neuroretinal rim? By effectively neutralizing this pressure gradient, we arrest the apoptotic signaling that would otherwise lead to total optic nerve atrophy. The pathology begins when a blocked trabecular meshwork prevents the egress of aqueous humor, transforming a balanced hydraulic system into a pressurized chamber. Notice how the resulting intraocular pressure buildup forces the optic nerve head to excavate, a process called cupping, which is visible in the stark contrast between the healthy neuroretinal rim and the enlarged white physiological cup. As this mechanical stress triggers the progressive apoptosis of retinal ganglion cell axons, why do we see the visual field contract centripetally into the tunnel vision shown in these progression simulations? The cross-sectional diagrams demonstrate that the blockage at the drainage canal transmits energy through the vitreous body, focusing destructive forces directly onto the optic nerve's exit point at the lamina cribrosa. Notice the direct causal link between the volumetric increase of the optic cup and the functional decay of the visual field's periphery. In the transition from panel A to B, the thinning of the neuroretinal rim indicates the loss of specific ganglion cell axons, which manifests as those expanding dark arcuate scacomas on the perimetry plots. As we reach the advanced stage in panel C, the optic disc exhibits nearly total excavation, meaning the majority of the 1 million nerve fibers have undergone apoptotic failure. This specific pattern of axonal destruction explains why peripheral orientation is sacrificed long before the macular fibers fail, ultimately producing the isolated island of central vision depicted in the extreme glaucoma profile. We are entering the domain of ocular oncology, where the focus transitions from inflammatory and degenerative processes to the dysregulation of cellular proliferation. This involves analyzing how genetic mutations bypass the standard cell cycle checkpoints, leading to both benign and malignant growths within the globe and its surrounding adnexa. We must distinguish between primary intraocular tumors, such as retinoblastoma or uveal melanoma,
and secondary metastatic lesions that capitalize on the high vascularity of the choroid. How do you suppose the blood-ocular barrier's integrity influences the probability of a systemic malignancy seating itself within the retina compared to the iris? Mastery of this section requires us to identify these neoplastic shifts, which threaten not only the preservation of vision, but also the systemic survival of the patient. Retinoblastoma originates from a biallelic mutation of the RB1 tumor suppressor gene on chromosome 13, which triggers the uncontrolled proliferation of immature neuroectodermal cells and forms the opaque calcified masses visible in these pediatric fundus images. Why does this intraocular mass specifically present as leukocoria, the abnormal white pupillary reflex shown in these clinical photos, instead of the typical red reflex generated by a healthy retinal vascular bed? In contrast, uveal melanoma represents the most frequent primary intraocular malignancy in adults, arising from the neoplastic transformation of melanocytes within the vascular tunic, often manifesting as the dark, elevated choroidal lesions seen in our lower panels. What physiological factors within the high-flow choroidal circulation do you suspect contribute to this tumor's aggressive tendency for hematogenous metastasis, specifically targeting the liver? Distinguishing between the white endophytic growth pattern of retinoblastoma and the pigmented dome-shaped architecture of a melanoma is vital for initiating the correct cytostatic or surgical intervention to preserve both the eye and systemic health. Let's dissect the microscopic architecture that distinguishes these two lethal intraocular malignancies. In retinoblastoma, we identified the Flexner-Winter-Steiner rosettes, where neoplastic cells encircle a distinct central lumen to mimic primitive photoreceptor differentiation, and Homer-Wright rosettes, which lack a lumen and instead cluster around a fibrillar neuropil. Transitioning to the uveal melanoma sections, notice the high density of atypical melanocytes and the characteristic brownish melanin granules invading the vascular tissue of the choroid and ciliary body. Why would the specific presence of a hollow lumen in one rosette type signify a higher degree of cellular differentiation compared to the solid core variety? Mastery of these architectural patterns, luminal versus fibrillar, is the key to identifying the exact neurosensory or uveal origin of the pathological growth. Basal cell carcinoma represents the most prevalent neoplasm of the eyelid, specifically targeting the lower lid, where cumulative ultraviolet radiation induces malignant transformation in the basal layer of the epidermis. Observe the clinical morphology. These lesions manifest as pearly nodules with prominent telangiectasia, small dilated blood vessels, and can progress to central necrosis or a rodent ulcer as the tumor cells outpace their nutrient supply. Histologically, look at the bottom left image to identify the characteristic peripheral palisading, where the columnar cells at the edge of the tumor nests align vertically like a picket fence. While this malignancy is notorious for being locally invasive and infiltrating deep into the dermal and tarsal structures, why does its extremely low metastatic potential make surgical excision typically curative compared to other periocular carcinomas? We are now shifting from theoretical analysis to the active application of these pathological principles through a series of rigorous clinical scenarios. Can you recall the exact biochemical cascades and structural failures that distinguish a retinal vascular occlusion from a tractional detachment? Prepare to utilize the genetic and anatomical frameworks we have mapped, from the 11p13 chromosomal deletion to the precise collagen lattice of the corneal stroma, to differentiate between these diverse ocular pathologies. This interactive assessment serves as a final diagnostic tool for your own mastery, requiring you to synthesize everything from adnexal microanatomy to the complex cellular architecture of intraocular oncology. Examine the symptomatic presentation of this 32-year-old, where nocturnal stagnation of inflammatory byproducts leads to the hallmark morning crusting and burning associated with blepharitis. Our primary management focuses on warm compresses to achieve a phase transition in the sequestered meibomian secretions, coupled with mechanical hygiene to eradicate the microbial biofilm. Why does the resulting chronic inflammation of the lid margin inevitably compromise the integrity of the precorneal tear film, as highlighted in our second question? This ongoing architectural disruption specifically targets the lipid-secreting glands, stripping away the evaporative barrier and subjecting the underlying corneal epithelium to the desiccating stress of dry eye disease. Evaluate the physiological sequence. How does a failure in the eyelid's adnexal function cascade into a breakdown of the entire ocular surface's metabolic and refractive stability? We are analyzing a chronic granulomatous state where a painless, firm nodule points directly to an obstruction within the meibomian glands of the tarsal plate. Unlike the acute suppurative infections of the glands of Zeiss or Moll, this condition, a chalcogen, results from a sterile inflammatory response to sequestered lipids. Our primary management utilizes warm compresses to achieve a phase transition, lowering the viscosity of the trapped meibum so it can be expressed through the glandular duct. If conservative measures fail to resolve the lesion, we proceed to surgical incision and curettage to manually evacuate the granulomatous material. Considering the anatomy of the lid, why would an obstruction in a deeper tarsal gland produce a firmer, less mobile mass than one in a superficial sebaceous gland? Look at this specific clinical triad: painful swelling at the medial canthus combined with purulent discharge, which points us directly toward an inflammatory crisis in the lacrimal sac, known as dacryocystitis. As indicated in our answers, the underlying mechanism is a nasolacrimal duct obstruction, which eliminates the hydraulic gradient necessary to drain fluid into the nose and creates a stagnant pool. Without this drainage, the sequestered fluid serves as a nutrient-rich medium for rapid bacterial colonization and subsequent suppuration within the sac's walls. How would you differentiate the anatomical boundaries of this medial swelling from a generalized periorbital cellulitis or a localized hordeolum of the eyelid? A gritty sensation paired with fluctuating vision indicates a loss of homeostatic stability in the aqueous tear layer, which functions as the eye's first and most critical refractive surface. When this film's kinetic stability is compromised, the resulting irregular light bending and increased mechanical friction on the ocular surface directly disrupt the visual pathway. Why does untreated tear film dysfunction specifically target the corneal epithelium for secondary damage? This occurs because the persistent lack of hydration triggers a cascade of desiccating stress, causing the stratified squamous cells to lose their structural integrity and undergo apoptotic failure. By identifying the aqueous layer as the primary site of failure, we can predict the subsequent breakdown of the cornea's biological and optical defenses. Focus on the optical consequence of fibrotic scarring. The primary property lost is transparency, because the precisely organized stromal collagen is replaced by a chaotic matrix that scatters incoming photons. Analyze this structural failure. Why would alterations in vascularity or thickness be insufficient to explain the sudden drop in visual acuity compared to a loss of clarity? Since dense opacities involve permanent architectural damage, we must bypass pharmacological limits and utilize a corneal transplant to restore the eye's refractive window. How does the cornea's immunological privilege, maintained by its lack of blood vessels, influence the surgical prognosis for this type of tissue replacement? A contact lens wearer presenting with acute nociceptive pain and extreme light sensitivity points squarely to keratitis, an inflammatory crisis of the cornea, often exacerbated by microbial colonization trapped beneath the lens surface. Why does this transition from simple irritation to structural degradation occur so rapidly? The inflammatory response triggers a massive influx of leukocytes that release proteolytic enzymes, which can liquefy the precisely organized collagen of the corneal stroma. If we fail to neutralize the pathogen and dampen this biochemical cascade, the cornea progresses from superficial keratitis to full-thickness ulceration, essentially creating a necrotizing pit in the eye's primary refractive window. Consider the biomechanical barrier of the eye. Once the basement membrane is breached, what prevents this localized ulceration from advancing toward a complete corneal perforation? Analyze the clinical constellation of a painful red eye combined with photophobia, which signifies a localized inflammatory breach of the blood-ocular barrier, known as uveitis. This intense light sensitivity occurs because leukocytes infiltrating the aqueous humor cause the ciliary body and pupillary sphincter to spasm, triggering acute nociceptive signaling. Since the uveal tract is a highly vascularized tunic, It frequently serves as a secondary site for systemic autoimmune responses, where autoreactive T cells misidentify ocular proteins as foreign antigens. How does this molecular mimicry explain why a patient's joint inflammation might suddenly manifest as this sight-threatening intraocular crisis? Utilizing this diagnostic link allows us to move beyond the eye to identify underlying systemic failures in immune regulation. Identifying the molecular driver behind a total absence of the iris requires looking at the PAX6 gene, which functions as the master transcription factor coordinating the entire embryological assembly of the eye. Without the specific signaling instructions from PAX6, the neuroectodermal layers fail to migrate and form the iris diaphragm, resulting in the profound structural void we define as aniridia. This developmental arrest frequently leads to secondary glaucoma because the residual iris stump can mechanically rotate and obstruct the aqueous outflow pathways within the trabecular meshwork. Why would a failure in the anterior segment's light regulation diaphragm inevitably trigger this hydraulic collapse and the subsequent destruction of optic nerve axons? Integrating these genetic links, from chromosomal deletions to hypertensive complications, is essential for predicting the global ocular decay that follows a primary PAX6 mutation. The distinct keyhole morphology of an iris coloboma is a direct anatomical marker for the incomplete fusion of the choroid fissure, the transient ventral biop in the developing optic cup. If this embryonic zipper fails to close by the 7th week of gestation, it leaves behind a permanent architectural void that can span multiple layers of the posterior and anterior segments. Why do we consistently find these defects in the inferior quadrant rather than the superior or lateral aspects? This precise localization occurs because the choroid fissure is situated exclusively on the ventral surface of the invaginating optic stalk, meaning any failure in its structural obliteration is strictly confined to the bottom of the ocular globe. Cataract stands as the primary cause of reversible blindness on a global scale because, unlike the irreversible axonal death in glaucoma or the atrophic changes in macular degeneration, the visual axis can be restored by surgically addressing the pathological lens. The fundamental pathophysiology here is lens opacity, where the high concentration of crystalline proteins, normally arranged in a precise, hydrated lattice, undergoes chemical modification and aggregation, resulting in light scattering rather than transmission. Why does this biochemical shift from a clear refractive engine to an opaque barrier make the condition uniquely reversible through the removal of the denatured tissue and the insertion of a synthetic intraocular lens? We must distinguish this localized proteinaceous failure from corneal edema or retinal ischemia, as the preservation of the neurosensory layers ensures that once the light-blocking opacity is removed, the neural pathway to the visual cortex remains fully functional.
When a premature neonate is subjected to high-tension supplemental oxygen, it triggers a biphasic metabolic response, where initial vessel regression is followed by a massive release of vascular endothelial growth factor, confirming our diagnosis of retinopathy of prematurity. Why do these fragile neovascular tufts represent such a grave threat compared to the stable original vasculature? This aberrant growth serves as a scaffolding for myofibroblasts that, upon maturation and contraction, exert significant centripetal tension, leading directly to the complication of tractional retinal detachment. This structural failure signifies a total metabolic separation between the neurosensory retina and its underlying pigment epithelium, effectively terminating the visual cycle.
Identify the initial cellular shift in diabetic retinopathy, where chronic hyperglycemic stress triggers the selective apoptosis of intramural pericytes. This loss of structural support causes the capillary basement membrane to yield under physiological pressure, forming the focal saccular outpouchings known as microaneurysms, which serve as our earliest diagnostic marker. Transitioning to the second prompt, the fundamental mechanism of vision loss is widespread vascular damage, characterized by a catastrophic failure of the blood-retinal barrier. How does this systemic endothelial collapse lead to both the hydraulic displacement of the macula via edema and the mechanical destruction of the retina through fibrovascular traction? The focal degradation of high-acuity perception in an aging population primarily signals a failure within the macula, leading us directly to age-related macular degeneration as the most probable diagnosis. While the dry variant involves slow metabolic attrition, the transition to the wet form is defined by the sudden pathological growth of choroidal vessels into the subretinal space, a process known as neovascularization. These aberrant, fragile vessels disrupt the anatomical barrier of Bruch's membrane, causing exudative changes and fluid leakage that catastrophically distort the foveal architecture. Why would this specific angiogenic surge result in a rapid rather than gradual collapse of central visual acuity compared to simple retinal pigment epithelium atrophy? By identifying neovascularization as the hallmark of the wet subtype, we can pinpoint the moment when a chronic metabolic decline converts into an acute, vision-threatening exudative event. We are differentiating two vascular catastrophes. The cherry red spot signifies a central retinal artery occlusion, where global ischemia turns the retina pale, while the thin fovea reveals the unaffected choroidal blood beneath. Contrast that with the blood and thunder pathology of a central retinal vein occlusion. Why does a venous blockage create such a violent hemorrhagic display compared to an arterial one? It is a matter of hydraulics. The venous obstruction generates massive back pressure that ruptures capillaries across the entire fundus, whereas the arterial blockage simply starves the tissue of oxygen, leading to instantaneous whiteout edema. Recognizing these distinct fundus signatures allows us to instantly triage between an acute ischemic stroke of the retina and a high-pressure congestive failure. The clinical triad of photopsia and sudden floaters signals that the vitreous body is exerting mechanical traction on the neurosensory retina, causing the brain to misinterpret physical stress as bursts of light. As this traction progresses into a full retinal detachment, the resulting curtain across the visual field represents the literal hydraulic separation of the photoreceptors from their underlying metabolic support, the retinal pigment epithelium. This catastrophic structural failure is most frequently triggered by a retinal tear, a full-thickness break that serves as a portal for liquefied vitreous humor to infiltrate the potential subretinal space. Once this fluid accumulates between these histological layers, it generates the hydrostatic pressure necessary to peel the retina away from the choroidal blood supply, transforming a localized break into a global ischemic emergency. When a pediatric patient presents with leukocoria, we are observing a pathological reflection where an intraocular mass, specifically a retinoblastoma, replaces the normal red reflex by physically obstructing the light path to the vascularized choroid. This malignancy is fundamentally driven by a biallelic inactivation of the RB1 tumor suppressor gene, a critical regulator of the cell cycle located on the long arm of chromosome 13. Without the functional RB1 protein to sequester E2F transcription factors, immature neuroectodermal cells bypass the G1S checkpoint and undergo rapid malignant proliferation. In the context of Kunzman's Q-hit hypothesis, why would a germline mutation necessitate only one additional somatic event to trigger this total genomic failure, compared to the two spontaneous events required in sporadic cases? In the landscape of adult ocular oncology, we must categorize melanoma as the most prevalent primary intraocular malignancy, setting it apart from the pediatric-dominant retinoblastoma. If these malignant melanocytes breach the vascular tunic, why do they bypass the lungs and brain to demonstrate such a potent tropism for the liver? This systemic spread is dictated by a specific venous drainage trajectory and the presence of molecular homing signals that find a compatible biological niche within the hepatic microenvironment. Given the high-flow nature of the choroidal circulation, what physiological barriers must these neoplastic cells overcome before they can successfully colonize distant visceral organs? In the context of glaucoma, the primary driver of neurosensory degradation is a pathological elevation in intraocular pressure, which exerts direct mechanical stress on the axonal fibers at the optic nerve head. Why does this hydraulic surge specifically target the ganglion cell axons at the lamina cribrosa rather than triggering generalized retinal ischemia? To arrest this apoptotic cascade, our first-line pharmacological strategy utilizes prostaglandin analogs, which function by biochemically enhancing the uveoscleral outflow of aqueous humor. By decreasing the fluid volume within the globe, we effectively recalibrate the pressure gradient to prevent the progressive excavation and total atrophy of the neuroretinal rim. Connecting the marfanoid habitus to ocular architecture, we identify the supratemporal subluxation of the crystalline lens as a direct consequence of a defective fibrillin 1 protein, which compromises the tensile strength of the ciliary zonules.
Why does the metabolic failure in homocystinuria, characterized by elevated systemic homocysteine, specifically drive the lens into a contrasting inferonasal displacement? This downward shift is a critical diagnostic marker, often coupled with developmental delays and a heightened risk for life-threatening thromboembolic events. By analyzing the vector of displacement alongside systemic, skeletal, or cognitive findings, can you determine which molecular pathway, structural protein synthesis, or enzymatic metabolic regulation has fundamentally collapsed? This concludes our deep dive into ocular pathology. Carry these diagnostic frameworks forward into your clinical practice.